today. The introduction will do a little bit of the pathophysiology of atrial fibrillation. We'll be assessing stroke risk in patients with atrial fibrillation. We'll check anticoagulant options for this treatment. We'll also look at choosing the right anticoagulant, the factors to consider. We'll also look at the roles of pharmacists in the management of atrial fibrillation, managing bleeding complications, special populations. So just to in a brief, we'll say atrial fibrillation is actually a heart rhythm disorder, just usually characterized by irregular beating of the heart. It might be increased beating or lower one, leading to blood clot formation. And this can actually cause either stroke, heart failure, or increased mortality rate generally. Atrial fibrillation is actually more prevalent in men than in women. Then in rich countries, it's actually coronary artery disease and hypertension are actually the main causes, while in other countries, we have rheumatic heart disease, which is actually caused by throat infection, such as strep. Yeah, strep can actually cause this rheumatoid heart disease when the valve of the heart becomes damaged. So we will also talk about types of atrial fibrillation. We have the paroxysmal atrial fibrillation and the persistent atrial fibrillation. Now, the paroxysmal atrial fibrillation is actually the one that actually occurs spontaneously, like quickly. It can happen anytime and it goes on its own. It can happen and goes on its own. While the persistent one, it happens and it doesn't go on its own. It requires treatment with what we call cardioversion. Cardioversion is actually a method whereby it can actually be chemical cardioversion or electrical. In electrical, we use what we call a defibrillator. Hello? Sorry, someone was... Okay. So we use a defibrillator to actually pass little charge to the heart to correct the beating of the heart. Also, research has actually shown that the success in the treatment of atrial fibrillation is actually dependent on basically two factors. One is actually... Sorry, can everyone hear me?
Yes, carry on. We're listening.
Yes, yes.
Carry on. We can hear you.
Yes, we can hear you.
Research has actually shown that the treatment of this atrial fibrillation is actually dependent on two things. That is the length of time which this event has actually occurred and the distance of the left atrium, the distance of the left atrium. So if the distance is less than 5 cm, there's higher success rates when it comes to this treatment. If it's between 5 and 6, there's actually moderate success. And it will also depend on individuals. It will vary based on individuals. Then if it's more than 6, the success rate is actually very little. So we'll talk about the pathophysiology of atrial fibrillation. This will help us to understand how these anticoagulants work. Understanding the pathophysiology will also help us to understand how anticoagulants work. Basically, what is happening in atrial fibrillation is that, normally the heart, in the heartbeat, the upper part is supposed to kick first before the lower part. That's the atrium kicking first before the ventricle. Now, when someone is actually having this atrial fibrillation, it disrupts this process and it doesn't kick very well. And that's known as an atrial kick. Now, it normally impels the flow of blood. Let me say the blood was supposed to pump out, let's say something like 10 mils, for instance. This condition might limit the amount of blood that will be pumped out. Now, and there might be blood clots within that region, that pool. And these blood clots, maybe let's say when the clot is actually pushed out, then there will be the blood clots now go to probably to the vessels of the brain and block there, maybe blocking the amount of blood that reaches the brain, and it might lead to stroke. I'm just trying to paraphrase or summarize it because of time. Then we'll actually consider risks, assessing stroke risk in patients with atrial fibrillation. Now we use this charts. It's known as, I call it CHADS VAS score. That's CHADS VAS score. Now, where the C, I hope you can see the slides, where the C stands for congestive heart failure. That means if you have congestive heart failure, it's like +1. You are prone to having this atrial fibrillation. You are prone to having this stroke as a result of atrial fibrillation. That's having congestive heart failure is a +1. Having hypertension is another +1. When you are your age, older people are more prone to having this disease condition. So diabetes mellitus also adds to it. Prior stroke also adds to it. Vascular diseases also add to it. Sex. Someone might be asking, why am I putting female here? When I said something like men are more prone to atrial fibrillation than women. So here, the next slide will help us. Now, if you check the notes in this next slide now, it says notes, women with a score of 1 due to sex alone might not require anticoagulation. So if you're a woman and let's say your total score is 1, it doesn't really mean you are having, you need medication to treat this disease condition. Now, when your score is actually 0, you don't need anticoagulation therapy. When it is actually 1, it stands for immediate risk. That means you might be considering treatments immediately with anticoagulants based on individual bleeding, and you consider bleeding, the risk of bleeding, and the risk of stroke. Now, if the score is greater than 2, it is recommended that you start the therapy, the anticoagulation therapy, immediately, and then usually direct oral anticoagulants like apixaban and dabigatran and the rest are actually preferred over warfarin for safety and convenience. We'll still talk about that later on. So we'll now consider. So we'll talk about anticoagulant options. To better understand how anticoagulants works, because I know there's every possibility that some people here might not be pharmacists. Maybe the link was actually shared to them. We might need to understand the coagulation factors cascade. And I, because of time, I might not be talking about it, but let me just summarize briefly. You know, when someone has an injury, external injury, the platelets wants to clot, and the coagulation cascade is being activated. Generally, the coagulation cascade, that's, let's say, the healing, let me use the word, let me call it maybe the healing mechanism. It actually involves 2 pathways. That's the intrinsic and the extrinsic pathway. The extrinsic pathway is that one we are seeing when there's injury. So basically, it's when this extrinsic pathway is actually activated, it activates other blood clotting factors. We call them blood clotting factors, starting from the tissue factor to factor 7. That's that. Although I would really appreciate if the non-pharmacists here, maybe they can look it up or something. But the idea is that this anticoagulant actually acts on these clotting factors. For instance, when the injury happens, the first thing that is actually activated is the tissue factor, which goes on to activate the factor 7. Now, the factor 7 goes on to activate factor 10. Now, the factor 10 is actually let's say, the bridge between the intrinsic and the extrinsic pathway, and so on. Because of time, we'll talk about anticoagulants actually prevent blood clot formation and are commonly prescribed to reduce blood clots related risk in conditions like atrial fibrillation, deep vein thrombosis, and all. So the different types of anticoagulants, where I classified them. First, I classified as direct oral anticoagulants. And under it, we have the direct thrombin inhibitor. Remember, thrombin is one of these factors we are talking about. So these direct thrombin inhibitors, that means they will inhibit thrombin. An example is dabigatran. Now we have factor 10A inhibitors. That's XA, that's 10 in Roman numerals. That's activated factor 10 inhibitors. That means they will block the factor 10. The factor 10 blood clotting factor in the coagulation cascade. An example is the popular apizaban and endozaban. So we also have, it's important to note here that unlike warfarin, which we still talk about, these direct oral anticoagulants, the drugs act quickly and they provide consistent and predictable effects for preventing blood clots with low bleeding risk. So we'll talk about the vitamin K antagonist. Now, vitamin K, when we're in secondary school, they told us vitamin K is important for blood clots, and that's why they will advise us maybe take enough vegetables and all that. So another type of anticoagulants that we have is the vitamin K antagonist, and then the popular warfarin belongs to this group. They actually interfere with the vitamin K dependent clotting factors. These are factor 2, factor 7, factor 9, and factor 10. So we also have the heparins. And we can actually say we have unfractionated heparin, which binds to antithrombin and inactivates thrombin and factor 10A. Then we also have the low molecular warfarin under the warfarins. It's the only difference between this unfractionated heparins, sorry, not warfarin, unfractionated heparins and then low molecular weight heparins, that the low molecular weight heparins are more selective to factor 10. Example is enoxaparin. Enoxaparin is a perfect example of that. Then we also have the parenteral direct thrombin inhibitors. They are mainly used in patients with heparin-induced thrombocytopenia. Example is bivalirudin. Then we also have synthetic polysaccharides and all, which also inhibits the factor 10. So let's talk about heparin. Major things about heparin we need to know about heparin. First of all, heparin is absorbed poorly orally, and that is why most times it is given subcutaneously or is usually given an IV. It is not given intramuscularly to prevent the risk of hematoma. Now, when you give somebody heparin and you feel like maybe the person runs the risk of bleeding or overdose, protamine sulfate is actually the protamine sulfate is actually the drug for the reversal, or you can call it the antidote for heparin. That's heparin overdose, or when someone runs the risk of bleeding as a result of heparin being given. So another thing we need to understand about heparin is monitoring of heparin effects. Now, close monitoring, people on anticoagulants, because of the risk of bleeding, they should be monitored. That's the idea. Because of the risk of bleeding, they are usually monitored. Close monitoring of the activated partial thromboplastin time, which is this partial thromboplastin time is actually the measure of how long it takes blood to clot. That's it. It's actually necessary in patients receiving unfractionated heparins. So that's how we will actually know if this person is running the risk of bleeding as a result of the administration of heparin. So the levels of unfractionated heparin are actually measured by, first of all, protamine titration. Remember, we said protamine sulfate is actually the drug of choice to reverse the effect of heparin. So we want to measure, let's see the concentration of heparin now. We can actually do protamine titration. How is it done actually? getting a blood sample, maybe someone who has taken heparin, unfractionated heparin, and getting the blood sample, you add a particular amount of this protamine sulfate, and we measure the time. And normally the safe range for these unfractionated heparin is actually 0.2 to 0.4 units per mil. Then another way we can actually inhibit the effect of heparin is using drugs that act as inhibitors of the factor 10x. Remember, we said heparin acts on factor 10s. So these tests, now if we use we can use those inhibitors to actually test the anti-clotting activity of unfractionated heparins. So by measuring its effect on the clotting factor 10, so with a target range of 0.3 to 0.7 units per mil. So we can also talk about the low weight heparins too. So unlike unfractionated heparins, the low weight heparins, they are predictable in patients with normal renal function, and it usually does not require monitoring. Heparin is actually an example of its heparin. Another thing about heparin is typically used as a choice anticoagulant in the following situation: when you need immediate onset of reaction, when you need immediate anticoagulation. Remember, it is not taken orally. Since it's given subcutaneously and intravenously, that means the onset action is actually faster. In bridging therapy is simply when we need to change, when someone is actually going through a difficult time in his or her, let's say, health period, maybe when the person is in the hospital, and that's an important phase. So we can also use heparin instead of another medication. Then if the patient is hospitalized, because yes, the nurses will be there to give it at intervals and all. If the person has a renal impairment, unfractionated heparin in particular is used in patients with significant kidney disease, as it is not eliminated through the kidney like low molecular weight heparins or direct oral anticoagulants, sorry. So if you are also doing certain procedures and dialysis, you can also use heparin. So let's talk about warfarin. Like we said earlier, it works by inhibiting the factor K dependent clotting factors. And warfarin sold is usually available in 3 milligram or 5 milligram, usually administered once daily. Now, one of the major problems with this warfarin is that most people, when they take warfarin, they run the risk of bleeding, and you must always monitor your what we call international randomized normalized ratio, INR. So that's like, it's a way of monitoring if you run the risk of bleeding when taking warfarin. And then if, just like we said about heparin, when someone takes warfarin and runs the risk of bleeding, and we want to reverse the effect of warfarin, we simply administer a vitamin K compound, which is usually known as a phytonmethanidone. So we also talk about, sorry, am I still audible? Hello.
Yes, you are.
Am I?
We can hear you.
So we also talk about, we also need to monitor. Remember, we said people taking warfarin also run the risk of bleeding. So we also need to monitor these people taking this warfarin. So effective vitamin K antagonist therapy like warfarin is actually assessed using protothrombin time tests. Protothrombin time test is actually a measure of how long it takes also for blood to clot. Now, this protothrombin time test is actually standardized as the international normalized ratio, like I said earlier, INR. Now, for the targets we want for people taking this warfarin, when we measure their INR, is, let's say, 2.2. The ranges are 2.0 to 2.5 for deep vein thrombosis prevention, and then 2.0 to 0 also for pulmonary embolism and all. So, and again, we can see some value vary as high as, let's say, 2.5 to 3.5. Okay. So what are the things we need to consider, the key factors we need to consider while choosing anticoagulants? The first thing we should consider is, what is the condition of this person? So different anticoagulants suit different conditions. For instance, if the person is, let's say, post-surgery, it's preferable to use warfarin and direct oral anticoagulants than heparin, most likely because maybe the person is not there in the hospital. It requires being injected and all. So you see that this condition, when the person goes home, it's far better giving us tablets and all. Again, if we are trying to get a fast response, let's say we need quick onset of action during emergency, you won't be going for tablets. You won't be going for tablets that will take time for their onset of action to start. So you use heparin in such situations. If the person, for instance, cannot swallow, you see that we will prefer heparin. So when we are considering the route of administration, we also have to use factors in selecting our anticoagulants. Then another, is someone saying something? Okay, another thing we will consider is the monitoring needs. The monitoring needs, like, does this person have access to doing all these tests to monitor INR? If the person cannot be doing that, that means we cannot be administering warfarin, because remember we said when patients take warfarin, they run the higher rates of bleeding if they are not checking their INR, because when you check your INR, you can actually adjust the doses. So in such cases, direct oral acting anticoagulants are actually preferred. So again, I say bleeding risk. Warfarin has higher bleeding risks. I've been saying that since. So direct oral acting anticoagulants generally have lower risk, but may increase gestational gastrointestinal bleeding. Sorry. So the reversal option. So the availability of their antidotes, we also determine or also infer our choice of anticoagulants. Then the patient factor. If the patient is having kidney disease, the age of the patient, and all, then drug and lifestyle interaction. It's very important to know that warfarin interacts with plenty drugs. So we also have to monitor what this person is, the drugs this person is taking, and all. So what are the roles of pharmacists in management of arterial fibrillation? We've been hitting monitoring and all. We also play important role in monitoring all these patients taking anticoagulants. For instance, helping them to always check the levels of their INR levels. For instance, when they are taking warfarin, we also help them to ensure medication adherence, identifying possible drug interaction, adjusting those based on individual factors, individual patient factors. Let me say something about those adjustments. Sometime last 2 months, my dad is actually on anticoagulant. He had his operation, he did open heart surgery. And his valve, they said his valve was actually damaged, so they had to change it. So one of my siblings got this warfarin they brought from outside when they traveled, and came. He was taking warfarin here, one he bought here. That he was taking 7.5 milligram, that's a tablet and a half daily. So when they brought down, because it's still the same 5 milligrams, so he had to still divide it to 1.5 tablets to take to make 7.5 milligram daily. So he decided to go to check his UNTH, check his INR. Unfortunately, he was not able to see the doctor. When he came back home, he was lamenting because he went with my small sister that his INR was about almost 4.5. So when I came down and I was asking if they saw the doctor, they said they weren't able to see the doctor because they moved from Melbourne to Enugu. So when they got there, they weren't able to see the doctor. So I had to tell him since the INR is very high and he runs the bleeding. So we stepped down the dose because it seems the one they brought from outside was actually stronger. So we stepped it down from 7.5 to 5 milligrams. And when he returned the next week to go and check the INR, it was within the normal range again, 2.6. So we see how the INR can actually help. So these are the roles pharmacists can actually play in management of arterial fibrillation, patient taking anticoagulant. So how do we manage bleeding complications? How do we manage bleeding complications? First of all, we need to assess the bleeding severity. Yes, we need to assess the bleeding severity. If it's minor bleed, we can temporarily withhold the anticoagulants. But if it is a severe bleeding condition that this person is running the risk of, you have to stop anticoagulant and do supportive care. Again, another way we can also manage bleeding risk is reversal agents. So we've said something about warfarin. We can use vitamin K compound, direct acting or direct anticoagulant. We can actually use, we talked about for dabigatran, we talked about protamine sulfates. For dabigatran, sorry, we talked about, for heparin, we talked about, sorry, for dabigatran, we are talking about daruximab. Now, we can also do supportive care measures, giving fluids, blood transfusion, applying local hemostatics as needed. Then we can also identify what is causing this bleeding. It's possible sometimes it's not even the anticoagulants that is causing it. It can be, let's say, the person taking anticoagulants and still taking NSAIDs, which can prone the person to probably ulcer. So stopping the cause of bleeding also can also help manage bleeding complications. Then reevaluate anticoagulation. I'll say that maybe the person is running the risk of much bleeding, or maybe as a result of the person not check the INR and all. We can say fine. Hello.
Yes, we are with you. Carry on.
Okay. So we say we can actually reevaluate the anticoagulation depending on the risk. So we can step down from to direct acting, direct anticoagulants, direct oral anticoagulant, such as dabigatran. Then we can also do we can also educate and follow up, teaching patients the signs of bleeding, manage their diet. Diet management is very important because atrial fibrillation comes with so many. We will say something about diabetes. So imagine if the person is not managing what he or she is eating, and the person is diabetic, we see higher chance of bleeding and stroke. So we will also talk about the special populations to also consider when using anticoagulants. First of all, we said something earlier when we started. We talked about older patients being more prone to having risk of stroke as a result of arterial fibrillation. We talked about older patients running the having the risk of stroke as a result of the fact that they have this disease condition, arterial fibrillation. So people with chronic kidney disease too. But will be preferred. Why will be preferred? Because is actually metabolized and not. So we also check the history of bleeding. UOACs are actually preferred due to lower bleeding risk. And this time around, like I said earlier, we should avoid NSAIDs and always adjust the dosage as needed. Liver diseases and all. So warfarin is also preferred to an extent because, like I said, the dosage of warfarin can actually be adjusted. DOT actually used also cautiously, only in mild and kidney liver impairments. So we'll talk about pregnant women too. So the low molecular weight heparin is actually preferred due to safety. Warfarin can actually be considered after the person must have delivered if the person is actually breastfeeding. Then for mechanical heart valve, warfarin is actually most preferred because of its proven effectiveness over other anticoagulants. Then patients with cancer too are also to be considered. So in summary, managing anticoagulation in atrial fibrillation involves balancing the stroke prevention with bleeding risk. The choice of anticoagulant, such as direct oral anticoagulants or warfarins, depends on factors like stroke risk, kidney and liver function, and patient preferences. If this patient is like, I cannot be able to always go and check my INR, maybe because of the location, so we'll see that it will affect the choice of anticoagulant use. Regular monitoring, dose adjustment, and patient education are actually key to minimizing the risk and ensuring effective treatment, ultimately enhancing patient safety and outcome. So that will be the end. So let's look at a case study. I just did a little case study so that all of us, sorry, I've spent 25 minutes. So, but let me just wrap up with this case study. So let's say a woman, let's call her Mrs. L. She's 65 years old. Her medical history shows that she already had atrial fibrillation, and then she has a type 2 diabetes. She had a recent ischemic stroke like 4 months ago. She's hypertensive. Currently, no history of bleeding complications yet. Now, what she's presenting now, Miss L came to the clinic for a follow-up anticoagulation management after her recent ischemic stroke, which occurred while she was not on anticoagulation, sorry. Her CHADS VAS score, that's CHADX score, VS score, was actually 5. That's high. That means she's actually having a high risk of stroke. She was now advised to start. She was advised to start anticoagulation therapy after her stroke, but her major concern was about the potential risk of bleeding. The assessment. The first thing that was assessed was the key risk, the risk factor. Miss L's recent stroke heightens her need for effective anticoagulation to prevent reoccurrence. But her age, remember, she's diabetic and she's already 65 years old, slightly increases her bleeding risk. Now, the recurrent symptom, no current complaint, stable blood pressure, and no signs of bleeding yet. Now, the management plan. The evaluation of warfarin, first of all, evaluation of anticoagulant option. Warfarin, although effective, remember, one of her concern was she might run the risk of bleeding. So, although warfarin is effective, warfarin requires frequent monitoring of INR and has a higher risk of bleeding. So, direct oral anticoagulants are actually effective to prevent stroke with a simpler dosing regimen, generally have a lower bleeding risk compared to warfarin, especially in older patients. Then the choice of therapy, given Ms. L's stroke history and bleeding concern, apixaban, which is also under the direct direct oral anticoagulants was actually at standard dose was actually given to her because its favorable bleeding profile, particularly for intracranial bleeding. This will allow her to reduce stroke risk without the need for frequent blood monitoring required by warfarin. Then patient education was also carried out among the management. She was educated on the importance of medication adherence to ensure effective stroke. She was also taught on how to identify bleeding symptoms. She was also advised to avoid NSAID and review her diets. Follow-up plan. She was scheduled for a follow-up in 3 months to assess tolerance, adherence, and monitor blood pressure and any potential bleeding symptoms. The outcome was that after 3 months, there was no bleeding and she was tolerating apixaban well. So that's the end of my... Thank you all for listening.
Wow, thank you so much for that wonderful presentation. Hello, can you hear me?
Yes, I can.
Thank you so much for this very interesting presentation. And you ended up with a case study that made us really appreciate what you've been saying. Thank you very much. In the house, we have our chairman, our national chairman, Dr. Joseph Madu. I will be giving him an opportunity to talk a little before we take questions, comments, and also contributions for this presentation that we just had now. Our national chairman, Dr. Joseph Madu, you have the floor to say something.
Hello, good evening, everyone. Please, am I audible?
Yes, sir.
Yes, you are. Yes, you are very audible. Can hear you.
Yes, sir.
At a time, thank you very much. Happy New Year and Happy New Month to all of us. At a time, thank you, my dear. At the time, I was not hearing Dr. Timi again. So I was thinking my own network has not also been too good. But I was able to capture some things. Most importantly, the attendance at this first clinical meeting of the year, about 55 persons that I saw at a time. And that is very, very encouraging. I want to appreciate all the participants because I believe that without attendees or participants, whatever the presenter has prepared will just be a waste. If you prepare for a party and no one attends, you will not be happy. So Ebonyi State CPAN has prepared this and they are hosting us today, being the first clinical meeting of CPAN for the year, and the attendance is very, very good. I can also see some few members of our mentorship program. That's our mentees. A few of them, I saw them online too. I want to appreciate everyone and I want to keep on encouraging all of us. Sorry, am I still audible? Am I still audible, please?
Yes.
Yes, you are.
Okay, so I want to keep on encouraging all of us. First of all, let me thank the presenter himself, Pharmacist OC Confidence and intern pharmacists doing this great job on the platform of clinical pharmacists of Nigeria. Thank you very much, Mr. Presenter. It's not easy to prepare a lecture. Preparing a lecture like this is like preparing food. Most people will not know what happened in the kitchen. All they want to talk about is just serve me, serve me. So you have done it and we are very happy. I believe as usual, we have learned a lot. And this is the only way we can always meet up to the expectations of our patients and other healthcare professionals as we collaborate as members of the core healthcare team. Once again, thank you very much. Thank you, the moderator, and thank you everyone for the opportunity to speak. I want to apologize. My network wasn't too good, so I didn't follow up everything. But at least I thank God that I've also gained one or two things. Thank you very much, and God bless.
Should I look to the outside door? Should I look the door? Our national chairman, Dr. Madu. I wanted you to help because so we welcome questions, comments, contributions for this wonderful presentation. My national vice chairman, you are also here, Dr. Maureen Uwafo. Please, what do you have to say about the presentation?
Okay. Good evening, everyone. I hope I'm audible.
Yes, ma'am.
Yes, ma'am.
Okay.
Evening, you're audible.
You are
Okay,
audible.
thank you. I'm glad listening to this our young pharmacist confidence. You really touched my area of concentration, and that is anticoagulation. And you did a very good work. Bear in mind that you just graduated just basically a year ago. Thank you so much for bringing on board anticoagulation today. You did a very good work. I'm really proud of you. And I encourage you to continue your research on anticoagulation. And I welcome you on board so that we'll work together. Thank you so much. I have few comments, I'm not really ask questions. If I want to portray certain words or explanation you did. Okay. I love the word you use, popular warfarin, and that's what I call warfarin. It's the almighty warfarin. So thank you so much for using that word, popular. Okay, you mentioned about bridging therapy, and the explanation wasn't the right explanation, if I may say, but I want to put it right. Okay, why we do bridging therapy while using anticoagulation is this. For example, a patient that underwent open heart surgery, and that's in the theater, we use heparin because it can easily, the half-life is very short, and we can easily counteract if it's fed with potassium sulfate as it says. Once a patient entered into the ICU, we initiate injectable anticoagulation, right? For example, your daddy that underwent open heart surgery and they have a mechanical heart valve in situ. So what we do that we start bridging immediately. Why we bridge with either unfractionated heparin or lower molecular weight heparin, that's the enoxaparin, while we administer warfarin immediately. So we give both, for example, enoxaparin and warfarin. Our main goal is to start warfarin because you cannot use any other anticoagulation to give patients who had a mechanical heart valve. The only anticoagulation you can use is just warfarin. Because that warfarin can reach therapeutic or around 3 to 5 days. So, and we wouldn't want that patient to be exposed to risk of having stroke. Okay, so we bridge. We therefore initiate either heparin or enoxaparin while placing him or her on warfarin. So before the next 5 days, we'll continue to monitor the patient's INR, giving both warfarin and the enoxaparin as the case may be, until it reaches therapeutic. What do I mean by therapeutic? The INR must have reached 2. Once it reaches 2, we stop the injectable like enoxaparin or heparin and continue only with the warfarin. That's what we call bridging. And most of the time, our physicians, they don't bridge. And we pharmacists, it's our role to remind them, please, we need to bridge. Please prescribe enoxaparin. Okay, so that's what we mean by bridging therapy while giving anticoagulation. Okay, then warfarin is taken once a day at a particular time. Not just like you're taking antihypertensive once a day. You may take it in the morning, some take it in the evening. So no, we take warfarin once a day in the evening. So your patient is able to tell you the particular time he or she should take warfarin and be consistent with it, or else it will affect the outcome of the patient's INR. Okay, why do we do INR? It's not just to take the bleeding risk. Fine, it's one of the factors. It we normally use it to monitor our patient's adherence to the medication. Okay, so before we discharge them, their INR must have reached therapeutic, and we discharge. We may give 1 month dose.
Look at the book. That's what they say. Look, see, you have to read the whole book before you do that thing.
Okay, it helped me move the person talking. So the INR of that patient will help us to dose the warfarin while we are still checking, because if it's above the therapeutic rate, if it's super therapeutic, that means the patient is at risk of bleeding. So it helps us to monitor, adjust those as the case may be. Okay, I love what you said about your daddy's situation. You had open heart surgery. Was it at Orif?
No,
Hello?
UNTH.
When?
That's 2017.
2017. Okay, fine. I may have known him, I don't know. But that's why we pharmacists must have to bridge that gap. Okay? Because most of our patients don't bother seeing physicians anymore. Those that, your father is going to be taking warfarin throughout his lifetime.
Yes.
Okay? Yeah. So, because he wants to do INR, those is what he doesn't have any need to go and see the cardiologist again. We pharmacists take that road in doing today. So please, next time, give him my number. He should call me. I can monitor his warfarin far back there at Bonnie State, unless there's any other need to see a cardiologist. But we have so many patients that we are monitoring their anticoagulation. Another thing that for patients for anticoagulation, the indication depends. Okay, like we are talking about arterial fibrillation. They have a wide range of anticoagulants they can use based on what patient can afford. As you say, DOAC is okay because it has less monitoring, like that bigger strand. When your patient cannot afford it, you still have to fall back to the powerful warfarin. It's cheap, though it has started to be very expensive now, but you can't compare with DOAC. Therefore, we pharmacists must have to know how to monitor our patients' anticoagulation, especially those on warfarin. Then patient education is the key concerning anticoagulation management by the patients. The physicians do not have that time to educate patients that are on anticoagulation. It is the basically role of the pharmacist. Okay, because as you say, the bleeding risk. For example, patients on warfarin who has subtherapeutic INR is exposed to risk of having stroke. Those who have supratherapeutic INR are at risk of bleeding. Those who take any medicine, their life, diet, and so many things interact with warfarin as we are talking about. So we pharmacists need to really learn how to educate those patients. And for us in UNTH, we can't leave you on warfarin without educating you, and also give you a booklet from the pharmacy department that really explains to you why you're taking warfarin, when to take it, drugs to avoid, diet to avoid, and so on and so forth. So patient education is the key in managing patient anticoagulation, or else we may lose those patients because of ignorance, especially those who have mechanical heart valve that have to take it throughout their lifetime. For arterial fibrillation patients, some may stop after 3 months if they have corrected their reading, or else they will continue to take it. So education is the key. And we pharmacists will have a great role to play in managing our patients' anticoagulation. Let me stop now, please. Thank you so much for a wonderful presentation.
Wow, thank you so much, Ma, our anticoagulant expert. I have that booklet too. I got from you, a booklet from from your facility, UNTH. Thank you so much, man. Really appreciate it. Let me call on Dr. Peter Alphonsus. Your hands have been up. Sir, please.
Good evening, Dr. Chimipre. Good evening, presenter. Can you hear me, ma?
Yes, we can hear you.
Okay, that was a wonderful presentation. And I'm privileged to be among the participants. The presenter did a wonderful job. And I'd like to encourage him, just like Dr. Morin has done, to keep on it, because that's one of the major areas that pharmacists are going to have relevance. Just like he had intervened in his father's case and had a similar, experience. This time around, it was my younger brother who was misdiagnosed by a professor in one of the best hospitals in just private hospitals. I had gone to see him. When he called me, he had some challenges from work. They took him straight to the hospital. He was diagnosed as having spasticity, and the professor had prescribed diazepam injections and some other things. And when I went there, I saw a team of medical experts, about 4 of them. I decided to join their conversations. There and then, I actually advocated that I wanted an ultrasound to be done, Doppler ultrasound, and the man said no, there was no need and whatever. Eventually, I had to insist. And because I insisted and they didn't want it, I said I want my brother to be transferred away from the hospital, referral. So rather than giving up the patient, they decided to run that. Behold, he had deep vein thrombosis. That was how the cardiologist came into it. Immediately, heparin was prescribed, warfarin. So in line with what he had talked about, the bridging was done. I was part of it from the beginning. Even though I don't work in that hospital, but the fact that my brother was the casualty there. Just to let you know that we as pharmacists should not just sit down and assume that things will work. No, things don't work because they are going to work. They work because we make them work. And just like he's an intern pharmacist, he might accomplish a lot, even what some people that have practiced for ages would not. It is the interest and the passion that makes us to get relevance, I must say. And added to that, I had some clinical exposure with warfarin, patients of warfarin, especially with respect to common drugs like paracetamol and amoxicillin. So I'd like to remind us, especially those that are into core practice, to always look out for those interactions. Paracetamol, warfarin, and amoxicillin. Those are things we should look out for, and I'm sure it's going to influence our practice in no small way. Most of the things I'm going to say, Dr. Morin has said it. The diet part, especially when the patient is diabetic, you are telling them to eat vegetable, eat fugu and the likes. Those dark vegetables actually would interfere with the, with warfarin, because they have that vitamin K thing you're talking about. So we as pharmacists need to do beyond what we are doing. And good enough, some pharmacists are already making advances. Elsewhere, pharmacists, take charge of the INR, just like Dr. Morin has said they are doing, and I must applaud their system. It is not enough for us to attend presentations, but what are we doing in our own place of practice? It matters more than any other thing. Good enough, there's a handbook. How many pharmacists have this handbook? Please, let's get them, especially when you are in core practice. And people don't care. Once you say you're a pharmacist, people will ask you direct questions. They don't want to know whether you are working in the industry, whether you are in the community, whether you're in the hospital. So I advise that we actually get in touch and get to talk with people that have these hands-on skills. The hands-on, nothing takes over hands-on. So thank you for the presentation. I just felt it's something I should share my experience that had related to it, especially now that he talked about his dad and I had a brother. And ever since then, my brother has always been, close to me when it comes to therapy. I had educated him a lot about issues of deep vein thrombosis and warfarin, the likes. It knows them very well, knows what to do, what not to do. Just especially in the, heart surgeries, heart valve surgeries. Those are key areas. We cannot dodge from warfarin. In fact, warfarin is supposed to be the point of connection between pharmacists and physicians in most hospitals. Thank you for giving me the time.
Well, thank you so much, Dr. Peter Alphonsus. We are glad to hear from you too. Yes, let me call on Dr. Eshet. So you have the floor.
Thank you so much, Dr. Tinipri. Good to hear from you. Happy New Year to you. And also good to hear from my friend, Dr. Peter. It's been a while. First of all, let me appreciate the pharmacist's confidence. I thoroughly enjoyed your presentation, and you spoke with so much confidence, as your name says. And I'm quite excited because as an intern pharmacist, it shows that the CPAN mentorship program is working. And I look forward to seeing more interns and young pharmacists present at the national level. Having said that, I want to ask, because I always felt that the therapeutic benefits of the low molecular weight heparin far outweighs that of the unfractionated heparin. I didn't even know that fractionated heparin has some advantage over the low molecular weight, because most times in hospitals is the Clexane that is most likely prescribed. And I've hardly seen in heparin itself being recommended or prescribed. So I want you to throw more light at that. I want to know more of the advantage of the unfractionated heparin over the low molecular weight heparin. Thank you.
Yeah, thank you so much. Our presenter, pharmacist confident, please. Did you get the question?
No, please come again, please.
He wants you to throw
Okay.
more light on the different. Okay, yeah, you can repeat the question.
Okay, thank you. I want you to, because all the while I had the impression that the unfractionated heparin has no therapeutic advantage over the low molecular weight, because over time we have seen our physicians, our pharmacists always recommending that is the enoxaparin, the low molecular weight heparin over. I don't think I've seen a prescription with the unfractionated heparin. But today you made us to understand that the unfractionated heparin has some advantage over the low molecular weight, and should actually be used in some indications. So I wanted you to enlighten me more on that.
Okay, if I actually get that question well, so like I said, when I started, I'm just starting off. So I've been hearing doctor this, doctor that. So it will also be preferable when when I'm done talking, saying the little I know, basically from my research and maybe from observation. The first speaker, sorry, that spoke after me, I would also like her to also attend to the question. So, but I'll just make an attempt. Then, in case I don't answer so well, I also like her to take it up from there. So we talked about the heparins as a whole. Then we now said we had unfractionated heparin and we had the low molecular weight heparins. And if we could remember when I was also talking, I said something about, for instance, pregnant women, low molecular weight heparin being given to them because of it's the risk is actually attached to the unfractionated heparin. You know, we said earlier the factor 10. Remember when I started, I said something that understanding the pathogen or the way the coagulation cascade works will help us to better understand the right anticoagulants to use. And one of the major thing we should even know from this night's presentation is that low molecular weight heparins are more selective for the factor 10 and blood clotting factor. I remember when I started, I tried explaining something about the coagulation cascade. When I said it is the factor 10 that joins the intrinsic pathway and the extrinsic pathway. It's actually the core point in this coagulation factor. So it is more selective to the factor 10 clotting factor than an unfractionated heparin. That's it. So I don't know if I made sense. So,
yes,
but
yes,
if not, I also expect the other doctor to actually pick it up from there.
You made a lot of sense. I want to add more to what you said. Thank you so much. The advantage of heparin over let me say that's low molecular weight heparin. Okay, heparin you can reverse it. That's why we use it in the theater during surgery. Okay, you can reverse it. It has a very short half-life, unlike cleansing, that's the enoxaparin. And enoxaparin has a very long half-life. Okay, that's why we give it to our patients once daily. But you can't take once daily if you really want to cover your patient against DVT or any other thrombotic disorders. Okay, but this advantage you can wear off easily and you can monitor it using APCT, unlike low molecular weight heparin, like that's the enoxaparin. So, but for managing your patients in the ward, you don't need to start using heparin. Though we use it to bridge just for the few days. But if you want to help your patient against that is post-allergic or anything you want to do against thrombosis, you must have to, we prefer to use enoxaparin because your patient takes it one day. It can cover that patient for a whole day, unlike heparin. Okay, so that's good. And also, we don't like giving our patients heparin outside the OR because of what we call heparin-induced thrombocytopenia heat. If you see any patient having this adverse effect of heparin, you run away from heparin. And patient using heparin must be in environment or hospital where the healthcare professional can easily identify it and withdraw it and manage it immediately. Okay, and now when you are talking, I didn't hear you mention FFP, fresh frozen plasma. So when there is heat, you withdraw heparin and we start to manage that patient immediately. So we always use FFP to prevent risk of bleeding, especially patients with very high INR. We use fresh frozen plasma. Also, we prefer to use the enoxaparin when there is a renal impairment. Enoxaparin has the renal dosage. You can easily adjust the food of your patient based on the patient's serum creatinine or the creatinine clearance. But you cannot easily reverse enoxaparin. But you can easily reverse heparin by use of the protamine sulfate. Though some people still use protamine sulfate to reverse enoxaparin. So these are basically the pros and cons of each of them. Thank you.
Thank you.
Okay, thank you very much. I really appreciate it. I think I know better now. Thank you very much.
All right. Thank you so much, our presenter, pharmacist OC Confidence, the intern pharmacist from the Alex Ekweme Teaching Hospital, Abakaliki. So to round up today, we have to call on the coordinator of Ebonyi State I can see her on the call, Mrs. Chioma Okonkwo, who also doubles as the PSN chairman, Ebonyi State. Ma, please, you have the floor. We'd like to hear your comments, your contributions, and how you are pushing Ebonyi State CPAN in your how you are pushing CPAN in your state. You have the floor, ma.
Good evening, everybody. I appreciate us for being on this call this evening. I thank God for making today possible. I also appreciate pharmacist OC Confidence for showing up. A lot of work was put into getting him ready for
That's been thrown out here. Come back.
Would have loved to hear from her, but it's like her network too is also having challenge. I'm sorry we didn't start with an opening prayer. I don't know why. We're supposed to have started with an opening prayer, but we are going to round up with a closing prayer. But let me see if I can still get her. Otherwise, I will get somebody to represent Ebony to give us the vote of thanks for today's presentation.
Okay, can I speak on her behalf?
Okay, ma.
Okay, why I want to tell you that Trauma is doing a great work than that Ebony State. Being the chairman of TSN Ebony and still holding this post, it wasn't easy for her. Actually, she's even lodging to hand over to some other person. It's like all of them are really dodging to take over from her. So I just want to congratulate her. I really push her, and as I'm pushing her, she's pushing this our dear presenter. So today we've seen what God has done. So from Choma, we appreciate you for all you do there. Please don't relent. And I know that one day God will bring up somebody who will take over for you. Okay? So please continue your good work. Our dear presenter, please help Choma, help to be speak the gospel of Sipan down there at Ebony State and help us to bring more people into Sipan. On behalf of our dear national chairman, Dr. Joseph Mon, I want to appreciate Ebony State so much for making tonight's presentation possible. I also want to thank everyone who joined us in this simple meeting. And we started, as we said, next week is another day. Tell others that Sipan has started their simple meetings, and you'll be happy with it. Thank you so much.
Wow. Thank you so much, Ma. We really appreciate you. So our closing prayer will be taken by Pharmacist Charles Akinshete, FPSN. Sir, I can see you on the call. Please, you have the floor.
Good
Prayer.
evening, everyone. Good evening and Happy New Year. Permit me to say that. Thank you for fishing me out. I thought I was just going to be a listener. And congratulations to Sipan and well done, Pharmacist. Confidence, may your name continue to ring bell. I wish you the very best.
Thank you very much, sir. Amen.
Let us pray. Our Heavenly Father, we thank and bless your name tonight. To you alone be all glory and honor. Thank you for the gift of life. Thank you for the grace and the privilege to be counted among the living. Thank you for a new year. Thank you for 2024, what you did in the life of FMSC, the life of Sipan. Thank you for the conference that I held last year and for the success thereof. Thank you for the leadership of Sipan. Thank you for the leadership of PSN. And thank you for today. Thank you for this opening webinar that is opening the year 2025. To you alone be all the glory. And thank you for your son that you have used. Thank you for wisdom. Thank you for knowledge. Thank you for understanding. And thank you for where you are taking pharmacy to. Surely the future of pharmacy is bright and rewarding. We ask, O Lord Daddy, you continue to strengthen us and endear us, O Lord, to you, that we may not miss our path. We ask, O Lord, that pharmacy be impactful. In the end, let your name be glorified. Thank you, Heavenly Father. As we go to bed, go with us, guide us, protect us, lead us, and let us come back tomorrow and next time for another session full of energy, full of strength, and full of testimony. To you alone be all glory. For in Jesus' precious and mighty name we pray. Amen.
Amen. Good night, everyone. Sweet dreams. Sleep tight. Thank you all for coming.
Good night. Good night, everyone.
Good night, everyone.
Good night.